Thanks again for joining this TMA Live TeleTown Hall. It's my pleasure to kick off this live forum by turning it over to TMA President, Dr. David Flieger. Please go ahead, Doctor.
Hello again. I'm Dave Flieger, President of our Texas Medical Association. Thank you for joining us tonight for TMA's TeleTown Hall on the 2019 novel coronavirus, or COVID-19. I'm joined by Dr. Linda Villarreal, Chair of TMA's Board of Trustees. Linda, take it away.
Thank you, David. We are finishing the process of calling more than 27,000 physicians across the state of Texas. This takes several minutes, so over the next hour, you will learn about the COVID-19 threat in Texas from top state health officials and experts. You will hear federal and state situational and epidemiological updates. We will also talk about testing and about how you can prepare your practice and community. What should you advise your staff? What should you tell your patients? Our experts will cover all of that and more. Tonight's speakers joining Dr. Flieger and myself are Dr. John Hellerstedt, the Commissioner of Health at the Texas Department of State Health Services, Dr. Jennifer Shuford, the Infectious Disease Medical Officer at DFHS, and Molly Mailmen, a TMA practice consultant. Thank you all for joining us tonight. We also will answer your questions periodically throughout this call, so stay tuned for instructions on how you can ask them. We also want your answers to several poll questions. These are very important. We'll tell you how to reply to those when the time comes. Before we go further, I want to assure you we're presenting this call to you because TMA and the Texas Department of State Health Services take the coronavirus very seriously. We want to help you help your patients and your community as we face the reality of this worldwide epidemic. That is why your TMA Board of Trustees convened a task force on the coronavirus. Dr. Wendy Chung, Chair of the TMA Council on Science and Public Health, chairs this special task force. She also is Chief Epidemiologist at Dallas County Health and Human Services. David, we all know this is a very important issue, and we appreciate our doctors joining us for information on how to prepare.
That's right, Linda. With several deaths across the country and more confirmed cases popping up, including those in Texas, we knew it'd be important to convene this TeleTown Hall meeting as soon as possible. When you could best utilize this information. Since TMA is offering continuing medical education for this event, we need to ask a question at the end for CME credit. And I'm also going to go through the usual CME policy that I need to read, so bear with me for just a second. The policies and standards of the TMA, the ACCME, and the AMA require that speakers and planners for continuing medical education activities disclose any relevant financial relationships that they may have with any entity producing, marketing, or reselling or distributing healthcare goods or services consumed by or used on patients whose products, devices, or services may be discussed in the content of the CME activity. The content of this presentation does not relate to any product of a commercial interest, therefore there are no relevant financial relationships to disclose. The TMA designates this activity for a maximum of 1 AMA PRA Category 1 credit. The TMA is accredited by the ACCME to provide continuing medical education for physicians. Physicians who remain on the call for at least 53 minutes, that's 53 minutes, guys, will automatically receive CME credits. So here's tonight's learning objectives. Number 1, identify appropriate evidence-based criteria for evaluating suspected COVID-19 patients. Number 2, apply clinical and personal preparedness measures appropriate for the practice setting. And number 3, develop practice management contingency plans in the event of a community outbreak. Okay, so here's how to ask us a question and make a comment at any time during this event. please press the 0 key on your phone keypad. A TMA staff member will greet you. Please succinctly, I say succinctly, tell them your question or comment. Soon we'll connect you to ask your question of our experts. So now it's time for our first opportunity to hear from you, the hundreds and thousands of physicians across Texas on tonight's TMA call. In our first poll question of the night, how prepared is your practice to deal with COVID-19 outbreak in your community? So how prepared are you? Number one, press number 1 on your phone keypad if your practice is not at all prepared. Press 2 if you believe your practice is somewhat unprepared. Press 3 if you are unsure. Press 4 if you think your practice is somewhat prepared. And press 5 on your phone if you think you're very prepared. Again, that's press 1 if your practice is not prepared, 2 if it's somewhat unprepared, 3 if you're not sure, 4 if it's somewhat prepared, and 5, very prepared. We will tabulate the results and report them back to you shortly. Now I'd like to introduce our first speaker, Dr. John Hellerstedt, the Commissioner of Health for the Texas Department of State Health Services. Dr. Hellerstedt will report on the current situation and epidemiological overview at the state and federal level. Dr. Hellerstedt, thanks for joining us.
Thank you, Dr. Flieger. This is John Hellerstedt, the Commissioner for the Texas Department of State Health Services and proud TMA member. The Department of State Health Services is working with local, state, and national partners regarding the novel coronavirus situation. The efforts being taken are intended to prevent and dramatically delay the spread of novel coronavirus in our state. We value our partnership with Texas Medical Association in this effort, and we appreciate the opportunity to talk with you this evening. As you know, this situation became apparent in China in late December and early January. The spread of the virus expanded quickly with over 100,000 cases and over 4,000 deaths globally as of today. For comparison, of a total of 8,098 people worldwide became sick with the severe acute respiratory syndrome, or SARS, during the 2002-2003 outbreak. Of those, 774 died. In the United States, only 8 people had laboratory evidence of SARS. We have also seen the spread worldwide of the novel coronavirus to over 100 countries, with several hotspots in Italy, Iran, and South Korea. We anticipate we will see others. For the national perspective, for the United States, there are 647 U.S. cases and 25 deaths so far. The number of U.S. cases has increased by over 450 in the last week. There are cases in 36 states, including the District of Columbia. Of the 647 cases overall, approximately 564 constitute likely community-based spread. The fact that we have a significant community-based spread in the United States increases the chances of transmission, community-based transmission in our state. There are now 16 cases reported in Texas. 12 of these cases had similar international travel to Egypt. 6 of those cases are in Fort Bend County and 6 are in Harris County. We also have 3 cases in Collin County, 1 with travel to California, and then a couple of close contacts of that individual traveler from California. That transmission is really the first person-to-person transmission within our state, although it is among close family members of the same household. There was a case announced just today in Craig County who had also had travel to California. We will see more cases in Texas and will eventually have some level of community spread in our state, but all of our actions are intended to delay and reduce that as much as possible. Talking briefly about the clinical nature of the illness, we're certainly learning a lot about the basic science of the virus now. Some of the information from other countries and experience in Washington State and California have helped inform us. The current information indicates that about 80% of the patients have mild illness. About 15% result in severe disease, and about 5% are critical. Severe illness appears to be more common in those 65 and older and those with underlying health conditions. And symptoms include cough, shortness of breath, and decreased respiratory function. Illnesses may appear in as few as 2 days to as long as 14 days after exposure. Of course, we know there is no vaccine, there's no specific antiviral treatment, and the care is supportive. It is estimated that any vaccine is a year away from being available. I want to talk a little bit about the Texas hospital experience. To date, several Texas hospitals have been involved in evaluating and caring for patients with a history of travel to China and/or symptoms consistent with COVID-19. We don't have many details regarding the current cases in Texas hospitals, but I can share some information related to the almost 250 individuals who had resided at the Joint Base San Antonio-Lackland as part of the federal repatriation efforts. Of that cohort of 250 individuals total, about 6 individuals had to go to the hospital. 1 individual was treated and released related to a fall, in other words, not related to COVID-19 disease. 5 individuals were hospitalized with symptoms, 1 for 7 days, 1 for 5 days, and the rest for 2 days or less. The good news is that the hospitalizations have been relatively short, in part due to the lesser severity of the illness, and also because of the availability of the Texas Center for Infectious Disease in San Antonio, which is, we often refer to it as the tuberculosis hospital, that is a Department of State Health Services facility. We have been able to use some of our capacity at TCID to care for patients with no or mild or resolving symptoms in that facility. However, if we see the virus become more widespread, an option like this will not be available, as there will be basically just too many patients. All of us, including hospitals, need to prepare for this eventuality. I will stop here for now regarding the clinical and epidemiologic information and ask Dr. Jennifer Shuford. No, I'm not following the direction I've been given, so
That's good, John.
Dr. Please.
No, you're doing good, John. That's great. Now, interesting information. So the majority of the cases I'm hearing are basically those who traveled somewhere else and back to Texas. So it sounds like about a developing picture, and it sounds like the department is on top of things. So excellent. We'd like to give you the results of our first poll question, and that asked you how you were prepared as far as your practice is ready for COVID-19 outbreak in your community or not. And basically, if we look at this, about 60% of the docs say they're not at all prepared, unprepared, or unsure. About 30% say they're somewhat prepared, and we've got 9 or 10% here who say they're very prepared. So the 90% of us need to up our game and catch up with our colleagues. But I'm proud of them, and they're being prepared, and they need to reach out to their peers and help lift all boats, if you would. So very good. After the next segment, you will have your first opportunity to ask a question. A reminder to do so, please press the 0 key on your phone keypad and briefly tell the TMA staff member your question or comment. Then continue listening to the call in the queue, and at the proper time, we'll call on you to ask for your question of the panel. So this next portion is actually me relating some information. Dr. Wendy Chung originally was asked to be on our panel. Wendy, as many of you may know, is the chief epidemiologist at Dallas County Department of Health and Human Services and chairs our TMA Council on Science and Public Health. And also, Dr. Villarreal has appointed to her as the chair of the new TMA Coronavirus Task Force. So we're very proud of what Wendy and her task force are doing, but she had an emergency, as you might guess, at the last minute, and is tied up and wasn't able to be with us. So I'm going to go through some points that she asked me to relay to you. The first was to summarize a major point is that she felt that probably we wanted to make sure that who we were screening, and Dr. Chung wanted all of us to make sure that we're screening our patients before they come into the office. She wanted to stress to our patients, stress to our patients that they need to call first to our clinics and the staff so that they could protect themselves and be able to triage remotely. and respond to the patient's needs appropriately as to whether they came to the particular office or needed to go to a facility of more acute care. So we need to be able to prepare our office, and we need to make sure that we're reaching out. Dr. Chung felt that calling first also supplies the local health department should also occur with the local health department as far as patient referrals are concerned. Successful disease containment and community mitigation depends upon communication. Communication between medicine and public health, between physicians and healthcare facilities, and between your staff. She wants to make sure that we do not send our suspected cases unannounced to the local health department or unannounced to local emergency departments or to other clinics. So please call ahead was her number one point. Wendy's next point is that it's very consistent with what I've been trying to tell my colleagues as president of the TMA. Much of our role as physicians is to be a resource to our patients and our communities. We need to calm their fears and to be a sound medical expert voice on how to prepare and protect their families. We need to be willing to answer questions from local governments, school administrators, news media, and others to make sure that our patients are getting the right information. Finally, Wendy made the point that, in which I strongly agree with, that we as physicians have an ethical obligation to provide urgent medical care during emergencies such as this. Though it puts us at risk, there are precautions and measures that we can take to protect ourselves and still take care of our patients effectively. The ethical obligation also includes neither stigmatizing nor ostracizing anyone from receiving needed medical care, especially based on infection status. Dr. Chung is rightfully proud of the new task force she heads up. TMA's leadership, she wants you to know, has convened some of the best infectious disease physicians in the state to be poised to answer any questions you have on COVID-19, and we hope to continue to serve as a resource to you in order to keep ourselves, our practices, our families, and our communities safe. So now I'd like to go to the questions. So we have a few people waiting in line here. For those not in queue yet, remember to ask a question. Please press the 0 key on your phone keypad and briefly tell the TMA staff member on what your question is or your comments. And we'll go to the first question. First question is out of Austin, and the caller wants to know the advice that you would give for older physicians, providers, the risk factors as to whether or not to continue their practice. So, caller, are you there?
Yeah. So the question is whether, with providers who are in their 60s and 70s or even older, who have risk factors or who have a family member with risk factors like receiving chemotherapy for cancer or something like that, at this point when we don't have screening methods for the general population, what's your advice regarding their continued exposure to patients with respiratory illness and their risk for getting the illness and getting complications?
So, John, why don't we start with you? We're talking about, I guess, providers or physicians that are older and what their risk is.
Absolutely. Hi, this is John Hellerstedt. That's a question, really, I think each individual physician needs to answer for themselves. Obviously, if you're in practice and you're exposed, the fact that you have you're over 65 and if the person has other medical problems, it certainly puts them at higher risk. So I think that's really a decision based on your practice profile and your ability to maybe take some other protective measures in your practice that might create a barrier for that infection. And of course, I think a lot of it depends also on really how prevalent it is in the community. One of the things that I don't think I mentioned early on, this is evolving very, very rapidly. And so even though it's kind of hitting the sort of sequences that we thought it would, where it was overseas, then it comes over in a smattering, then we start seeing some imported cases, and now we are rapidly seeing the cases multiply in the United States. So I think it's a very personal decision for the doc based on the known risk factors and their practice profile.
Yeah, good advice, John. Our next question is from Dr. Malamud, and you'll excuse me if I butcher names tonight. I am terrible with names, but Dr. Malamud is from Burnett, and let's see, Dr. Malamud, are you on the phone?
Yeah, sure am.
Sure. Could you give us your question?
The question was, once the COVID test kits become available, where can we purchase them for our practices?
Good. We're going to have Jennifer Shuford answer that for us. Jennifer?
So I guess there's a couple different things. There's the equipment that you need to just obtain the specimen, and then there's test kits. And so the CDC, through their international reagent resource, has distributed test kits to our public health labs to be able to do the testing there. In order to obtain the specimens from the patients, you would need NP and OP swabs and viral transport media in a vial. And all of those specifications are on our website, our coronavirus website, at DSHS, and that will give you exactly what you need to obtain those specimens, and they are commercially available, and so you should be able to obtain those specimens with readily available resources.
Excellent. Thank you, Jennifer. Our next questioner is Dr. De La Cruz from Dallas. Dr. De La Cruz,
Hi,
go
good
ahead.
evening. Good evening. Clinicians and hospitals need a unified and clear voice on testing and the limitations of accessibility to testing at this time. Will the state provide clear information to patients to ensure that we avoid overwhelming emergency services just for asymptomatic or exposure testing?
Good question. We were actually talking about that before we started. So, John, I'll let you start with that since we had that conversation.
That's very good. That's an excellent question. For one thing, we're very proud of our Department of State Health Services website, which is dshs.texas, spelled out, .gov/coronavirus. We've got lots of information there for providers and the public as well. We really continue, again, to recommend to folks that they not seek testing or seek health care unless they're clinically ill. The difficulty, of course, I spent 20 years as a pediatrician in practice, and patients don't always understand or follow the advice that you give, and clearly we're in a situation where there's a lot of anxiety, a lot of public anxiety out there, to say the least, and again, to be quite frank, I think there's been confusion out there in terms of exactly how much testing is really available. We know that there's testing available through public health, and we would continue to use the screening criteria, and if people want the testing to be done through the public health assets, they would go through their health department as they had before. There's also testing available in commercial labs, and there, again, we think the wise thing would be to use your clinical judgment to look at the clinical guidelines that we have for testing, and then make a decision as to whether or not that individual could access the services of a commercial lab. So that's really the best answer I can give.
Excellent. No, that's a good answer, John. Thank you. Our next question is from Dr. DeLozer in Galveston. Are you on the line, Dr. DeLozer?
Good evening. How are you?
Well, thank you. Your question, please.
My question is, when they talk about the people that are isolated, they talk about not having air conditioning. I seem to recall that cold and flu season is in the wintertime, and I was taught that fever is part of the defense mechanism that people have against viruses and colds. Also, I didn't think that the fever needed to be controlled until it was over 102. Now, is that incorrect, or why don't we give them a hot tub and hot baths and hot showers and so forth as part of the way to try to control this?
All right. Jennifer, I'll let you take that one.
Yes, fevers can be protective to a certain point, but we don't have scientific data to show that warming somebody like in a hot tub or in a hot shower would be beneficial in ridding the body of this particular virus. And so, but we would definitely share that knowledge if we did learn that that was the case. But for now, you know, not only do we not have those sorts of interventions available to help treat this virus, we also don't have approved treatments like antiviral medications, like Dr. Hallerstedt just mentioned. And so I think there's a lot of treatments that are being tested right now, including in the United States, remdesivir, but we still have a long way to go in order to find some effective treatments for this.
Excellent. Very good. Thank you. We're going to go on to one more question here. Dr. Jose Aguirre in Houston. Can you hear me, Dr. Aguirre?
Yes, good evening, doctor.
Good evening. Your question, please.
Yes, we already talking about like to possible cases like to call in advance to the office, but what happens if the patient show up in the office without any medical appointment? Like what happened to me last Friday with a patient, older patient coming with a very respiratory distress. She came from New York, from some area when there are some cases from COVID-19. So my question is, if you have this potential case, if you will need a negative pressure room to isolate this patient, if it's a regular mask, it's enough to protect myself, because when this happened, I have only simple mask. I don't have any 95, we don't have any kind of negative pressure room. So what do you talk about this?
Good question. So where do we start with you, John? I mean, I guess the question is, somebody drops by the office, what should our office do?
Right. Hi, this is John Hallerstedt. So I just want to clarify, are we talking about basic outpatient office, or are we talking about an emergency department or a hospital?
Dr. Gary, you're in an outpatient setting?
Yes.
Private clinic?
Yeah, I'm in the outpatient setting. I am in the outpatient setting, yes. I am in the clinic, and the patient show up in the waiting area with a very bad respiratory distress. Everybody in panic. They start placing masks. So my question is, what happens if the patient happen like that?
Got you. Thank you.
Right. Yes. So that is several great questions. First of all, if the patient's symptomatic, if you have regular surgical mask, I would highly recommend that you put a regular surgical mask on them. That surgical mask is going to prevent that person from coughing and sneezing and basically spreading those droplets. It'll contain them to be a much more confined space than it would otherwise. And then use other types of infection prevention, infection control things if you've got gloves and gowns and that sort of thing. I don't think there's necessarily an expectation that an outpatient doctor's office would have N95 masks, and I'll get back to that in a second. And likewise, I don't think there's any expectation that doctor's offices have negative pressure. So what I would say is that person presents, you would do the normal things you would in evaluating a patient in the office and decide essentially what can I handle this patient's level of illness here, or do I need to essentially ask for them to seek care or arrange for them to be transported to an emergency department. So that would be the first step. I think the other one around sort of, if you will, droplet versus airborne disease, I think we really need to be practical about this nowadays. N95 masks are in short supply, even in places where clearly we would desire to have them, such as hospitals where there's aerosolized procedures or patients who are intubated. That's really the clear need for those N95 masks. And we need to conserve the supplies that we have in order to maintain being able to provide masks for the providers in a situation like that, so the providers can be healthy and free of infection. So I would just say do the best that you can in the setting. I think there's nothing wrong in a setting like that with not only putting a mask on the patient, but putting a regular surgical mask on yourself and staff as well. It's got to help.
Excellent. Good advice, John. Good questions all. Appreciate it. There will be another opportunity to ask little questions a little bit, but we're going to move on. And now I'd like to bring back John from the Department of State Health Services, along with Jennifer Shuford, DSHS Infectious Disease Medical Officer. Doctors, I know our colleagues are very curious about evaluating persons under investigation, PUIs, for COVID-19, quarantines, and how to prepare our clinics, and other important points. Doctors, please.
Hi, this is Jennifer Shuford. I'm going to start off. And first, I just want to thank you for being on this call tonight. Physicians really are key for identifying individuals in our communities who have COVID-19. And we really rely on you to be our eyes and ears in the community and appreciate all the times that y'all have brought outbreaks to our attention. And we do really value your input. So for COVID-19, we are asking that physicians base their decision to perform testing on both the epidemiology of COVID-19 as well as the clinical course of illness. Epidemiological factors that might help guide decisions on whether to test include whether that person has had close contact with a laboratory-confirmed COVID-19 patient within 14 days of symptom onset, or a history of travel from affected geographic regions within the 14 days of symptom onset. Signs and symptoms compatible with COVID-19, such as fever and acute respiratory symptoms like cough or shortness of breath, also play into that decision. So if a physician wants to test for COVID-19, there is right now a couple of options for testing. So one is to use commercial testing, just like you would if you were ordering a test for most other conditions. The other option is to use a public health lab. So Texas is really lucky to have this robust network of public health labs. We have our state lab in Austin, and we have another state lab in South Texas, as well as 8 other LRN labs, or Laboratory Response Network labs, across Texas. And even with this network of labs, though, our testing capacity is still somewhat limited. And so we do rely on PUI criteria to make decisions about testing. A PUI, or a person under investigation, is an individual who meets certain criteria for testing. And we have changed our PUI criteria a couple of times during this COVID-19 outbreak, both to account for the changing epidemiology of the disease, as well as to adjust to our testing capacity. Currently, our PUI criteria include both a combination of clinical features and epidemiological risk. So for clinical features, if a person has fever or signs and symptoms of a lower respiratory illness like cough or shortness of breath, and we know that they've been exposed to or have been a close contact of a laboratory-confirmed COVID-19 patient within 14 days of symptom onset, then they meet the first criterion. If there's fever and signs or symptoms of lower respiratory illness, and they've had either a history of travel from affected geographic regions within the last 14 days, or if they're an individual just who's at a higher risk of poor outcomes, like those people 65 years and older that have chronic underlying conditions, then they meet that second criterion. And thirdly, if a patient has fever and signs or symptoms of lower respiratory disease, and if there's no source of exposure that's been identified, but they do require hospitalization for their respiratory illness that otherwise hasn't, no etiology has been found, then they meet that third criterion for public health testing. And so what you may or may not notice is that these public health testing criteria reflect a focus just on a few particular populations. So we're focusing on healthcare professionals, since they are key to upholding our whole healthcare infrastructure. It's a focus on people with known risk factors for disease, such as travel to an area with community transmission, people who are in a high-risk category for poor outcomes, and then those very ill patients who are hospitalized without a known cause of illness. And so, like I said, these are our current priorities with the public health resources that we have, and this might change over time. So if a physician wants to access testing in a public health or an LRN laboratory, that physician should call the local health department about getting that patient tested. Now, if the patient meets PUI criteria, then that physician will get instructions on specimen collection and shipment instructions. If that physician knows that the patient does not meet criteria but still feels like that person needs to be tested, they should feel free to call the local health department anyway and discuss that patient. Each patient's circumstances are different, and we respect your clinical judgment. We do occasionally test outside of our testing criteria for those reasons. But thankfully, commercial testing for COVID-19 has been ramped up in recent days. So commercial lab testing continues to be available in those situations where an individual does not meet that public health testing criteria, or in locations where maybe the public health capacity is already overburdened. So two other things that are important for physicians to note, though, is that COVID-19 is a notifiable condition. So we do ask that you call your local health department to report any suspected or confirmed cases. And secondly, if a decision is made to test a patient, then that patient should be put into isolation. So if they're at home, then self-isolation, or if they're in a healthcare facility in an airborne isolation setting. If a physician does want to test a patient for the virus that causes COVID-19, which is also known as SARS-CoV-2, then certain specimens should be obtained. And we kind of briefly touched on this during one of the questions, but for initial diagnostic testing for SARS-CoV-2, or the virus that causes COVID-19, we recommend collecting and testing upper respiratory tract specimens, and that includes both a nasopharyngeal swab and an oropharyngeal swab. Lower respiratory tract specimens can also be tested if they're available. So if a patient has a productive cough, then you can collect sputum for testing. If a patient is intubated, you can get an aspirate or a BAL specimen for testing. But we do not recommend that that sputum be induced to get that lower respiratory specimen. We'd prefer, if they have a non-productive cough, just to use the NP and OP swabs. But specimens should be collected as soon as possible once a PUI is identified. Okay, and then lastly, I just wanted to touch on quarantine. So there are circumstances in which we are using quarantines to help control this outbreak. So just as a refresher, isolation refers to separating sick people with a contagious disease from people who are not sick. And quarantine refers to separating and restricting the movement of people who were exposed to a contagious disease to see if they become sick during that incubation period. Now, the federal government has used federal quarantine orders for the people who were returned from Wuhan, China, and from the Diamond Princess cruise. So these people were under legal quarantine orders. At DSHS, we have asked many people to voluntarily self-quarantine, that is, to stay at home for 14 days after their last potential exposure to COVID-19. And in our experience, people across Texas have been very willing to do this in order to protect the community around them. At this time, we continue to have people voluntarily self-quarantine for exposures that are high risk or even medium risk or low risk. We ask that they stay at home and monitor their health. However, some of these types of containment strategies will become less useful once community transmission begins to occur in Texas, and we will plan to change our recommendations as the circumstances change. And that is all I have. I'm going to pass it back to Dr. Hellerstedt.
Excellent.
Hi, this is John Hellerstedt again. Thank you, Dr. Shuford. Preventing and mitigating the spread of this virus is everyone's responsibility. We are asking community leaders to help us push hygiene messages of washing hands, covering coughs, staying home when sick, and cleaning and disinfecting frequently touched objects and surfaces. These are things that everyone can do to prevent the transmission of the virus. It's really basic, but it's also very important because it's some of the most effective tools that we have, especially in anticipation of the progression of the illness in North America. As physicians, people will look to us, look to you, as authoritative sources of information about the virus and people's risk. Please help us by promoting these preventive messages with your patients. Also, we need your help in advising patients regarding travel, and in other words, they might want to go to a foreign country, and steps that they might take if they think they have been exposed to the virus or if you suspect COVID-19. Also, because this disease is particularly severe for the elderly and those with underlying health conditions or compromised immune systems, we need to focus special attention on these populations at the clinical and community level. The Department of State Health Services and CDC websites contain a wealth of information and advice on vulnerable populations, including the elderly, travel, and regarding self-isolation and care at home. And Dr. Shuford has been extremely valuable in making sure that our DSHS website is up to date, and we know exactly what is out there in the medical literature, as well as what the CDC is providing. Being prepared is another important aspect of the response to the COVID-19, the novel coronavirus disease. Physicians should be prepared now for how to prepare, how to cope with the future, again, with the expectation that we will see more cases. Please review infection control protocols and how you might handle a suspected COVID-19 patient in your clinic. Consider your telephone patient screening procedures. Most of the time, these patients likely will not need to go to the hospital, but may need evaluation by a physician. Personal protective equipment has been a hot topic in this event, and as we said earlier, PPE, certain types of it, are in short supply. PPE is still available, but we understand that healthcare professionals and facilities are having a difficult time getting sufficient amounts and in a timely manner. The federal government is taking actions to try and increase this availability. Because this will not increase the supply in the short term, we are working with CDC to modify their guidance in recognition of the appropriate timing for appropriate settings, really, for airborne precautions versus droplet precautions. And we hope that this will allow us to better conserve our PPE inventories. Also, CDC has issued guidance on actions that can be taken to conserve the supply. We suggest that all of you look over these recommendations. For instance, not really using N19s for fit testing, for example. Finally, physicians need to be personally prepared. This is a major challenge. I personally think this is going to be the greatest public health challenge in living memory. And we want to do our very best to slow as much as we can the progression of this disease in our population so that we do not overwhelm our healthcare system and we can maintain adequate staffing for that. And so that requires everybody's cooperation. Please be thinking about personal preparedness activities that you can undertake to ensure that you and your family are prepared for COVID-19 and the challenges that will be present in our communities. This is a very dynamic situation. We will we'll continue to adjust our approach as time goes on. If you just think back and look at what's in the news, you can see that things change week by week by week in a very dramatic way. The Texas Medical Association and all of its members are critical parts of the Texas public health system. You are our partners in combating this virus, as you have been with many issues before. We have a long history of working together for the health of the people of Texas. This is a team effort, and it will take all of us to lessen the impact of the disease on our state. The Department of State Health Services always stands ready to work with you, and thank you all for what you're doing.
Excellent. Well, thank you, Drs. Hellerstedt and Shuford. We appreciate you both being here and providing such valuable information, and of course, all that you are doing to lead our state through this outbreak. I'd have to say it became very real to me on Monday when my 7:30 case was canceled because as my patient came through the door, he answered positive to 2 questions. He'd been in Italy in the last 2 weeks and he had a cough. Luckily, he ended up testing negative, but it became real that our hospital's screening at the front door and it works. So very good. We're going to move on, and before our next speaker, I want a little reminder to get in the queue to ask a question, make a comment. Just push 0 on your phone. A TMA staffer will get your name and the gist of your question and place you in the queue. We'll take audience questions again shortly, and we'll call you by name at that time. Now I'd like to introduce our next speaker, Molly Mailmen with TMA Practice Consulting, to talk about preparing your staff and clinic, financial preps, and other points. Molly, thanks for joining us.
Yeah, thanks for having me. So again, my name is Molly Mailman, and I'm a consultant here at TMA. So a couple items to address regarding preparing and educating your staff. Try to do as much as possible over the phone, including triage with appropriate screening questions, updating your internal phone tree, and revising the practice's emergency service notification to notify patients who call the after-hours line. You'll need to establish a location of choice with some sort of respiratory isolation capacity. So if you have a patient that answers those screening questions, you need to maybe put them in an exam room that is not currently away from your waiting room, so you can put them away from the other healthier patients. Should patients need to be redirected for care, identify where you're going to send them and have that in place. Also make sure that your and your staff's households are ready in the case. You will need to start preparing in case your staff is sick. Advise staff that are ill with fever or any respiratory symptoms to stay at home. Follow risk assessment guidance for staff exposure. allow staff to telecommute and perform certain tasks remotely, such as patient scheduling, refill requests, and billing. Make sure to cross-train all staff members in essential tasks in the event of being understaffed, so making sure your front desk and medical assistants can fill in when needed. Establish a relationship with a temporary staffing agency in case you do not have staff, and you can ask them to have temps trained in your specific EMR, so there's no lag in knowledge there. You may also want to identify housing options close to your practice to keep healthy staff healthy and away from sick family members. In the event you must temporarily close your practice, determine necessary staffing needs for catching up with additional evening or weekend hours. And the last point I want to make across is tips for financial preparedness. Anticipate and budget for incurring additional costs for overtime pay, temporary staffing, and increased supply inventory. Try to investigate telemedicine opportunities and other quickly implementable platforms that enable social distancing and provide an avenue to avoid or lessen diminished revenue. And then also review your insurance policy for business interruption protection. Markets for insurance may close with looming events and reopen when the event has passed, so make sure to contact your insurance provider quickly. Also work with local tenants, firms to help make sure if you have any physicians or mid-level practitioners that are out. Contact your local bank to establish a line of credit or payroll loan to cover operating expenses, such as accounts payable and payroll, and then be as liquid as possible and have cash on hand. And then recent news, a couple of insurances have reached out to us with statements such as Aetna, Blue Cross, Cigna, United, that they will not require prior authorization nor apply member copay or deductibles when you diagnose the COVID-19 when it's medically necessary and consistent with the CDC guidelines. Please make sure to check out our additional resources on our website regarding coronavirus and telemedicine. We have a disaster planning toolkit on our website to help prepare for the unexpected. And if you guys have any additional questions, please do not hesitate to contact the Practice Consulting Department, and our number is 1-800-523-8776. And thank you so much for your time.
Well, thank you, Molly. Sounds like it's time to tighten our belts. And I know already in our practice, we're seeing some of the elective patients deciding to defer appointments for right now. So I think even if we don't get infected by the virus, we're going to have some financial impact. So thank you for those words. All right, we're going to go on to some questions. And our first question is Dr. Justina Toby in Houston. Dr. Toby, how can we help you?
Well, good evening. It's Tauba. And
I'm sorry.
It's all right. The question is, for ophthalmology, we're really face to face with the patients. You know, we can smell their breath, and they can smell ours. That's how close we are. So, what are the recommendations for ophthalmology?
Hi, this is Jennifer Shuford. I don't know that there are specific recommendations for ophthalmologists, but we do know that we're recommending that people try to social distance right now, so stay 3 to 6 feet away from each other, and you cannot do that in your practice. And so I think some of the measures that you could take is, number one, if your patients do have a respiratory illness and the appointment can be deferred, I would ask them to reschedule. And then secondly, you can wear a mask when you're close to patients, and you might not have accessibility to N95 masks, for instance, but even having a surgical mask on can protect against some droplet transmission. And so I think between those two things, that would increase your protection from COVID.
Great. Thank you, Jennifer. Our next questioner is Dr. Lesser from Houston, has some questions. Yes, go ahead, please. Your question.
Oh, hi. I'm an emergency medicine physician, and I'm expecting a large amount of worried well to present to the emergency department thinking that they have COVID-19. So I need to be clear on a uniform way of discharging people. If I discharge them, perhaps if they don't meet the criteria that you guys mentioned for travel or lower respiratory symptoms or fever, I could tell them, okay, you can't be tested, go home. If they do meet some of the criteria, but they're not so sick and they could be tested, what do I do? the classic emergency medicine patient shows up at 2 in the morning on a Tuesday night. How do I access getting them a test? Do I send them home and call them with their result, or what should I do with the patient?
Good question. Jennifer.
So a lot of it's actually going to be up to just like the clinical decision making that you have to do all the time about whether if they're ill enough to be evaluated and or kept in the hospital. We are trying to get out some messaging across the state that people who are only mildly ill need to stay home and take care of their symptoms like they would just for the flu. But if they're in one of those more at-risk categories, that they need to call their physician to get some phone advice about how they should be cared for and if they needed to be tested. Now that testing is more widely available, you would be able to test from the emergency department. If, like I said, that patient doesn't meet criteria for public health testing, you could still access commercial testing. And I know that Quest and LabCorp are up and running already with testing, and Mayo and ARUP are planning to be up later this week. And so that there are options for that. And what we would ask is that if they are well enough to be sent home after testing, that they are just told that they remain in isolation, that they self-isolate even from other healthy family members until they get their lab results back.
Excellent. Good advice. Dr. Oliverson from Boulevardy. Good evening.
Yes, I have a real basic question. We keep talking about people being at higher risk if they're older or if they have underlying medical conditions. And I think we all have a general idea of what we mean by that, but I think it would be nice if you could briefly discuss what chronic underlying medical conditions are of most concern, and some others might not really be of concern.
Hi, this is Jennifer Shuford. Yeah, and so the ones that have that we've seen in earlier studies, say out of China, that really seem to impact the clinical course of COVID-19 include chronic heart disease, chronic lung disease, diabetes, hypertension, and other things that might lower the immune system, like cancer or immunosuppressive drugs, for instance. And so those are the health conditions that we're referring to when we talk about this chronic underlying health condition.
Good. Dr. Schwartz from San Antonio. Good evening.
Yes, thank you so much. I know we've been told that antiviral drugs like Tamiflu, Relenza, Xofluza do not have any effect on this disease, but I wonder if there have actually been any clinical trials. I know this is early in the disease. So I wonder first if there have been any clinical trials that show that these drugs do not have any effect, and also is there any information about if these drugs have been given fairly early in the disease before patients have been put on respirators. Thank you.
Hi, this is Jennifer Shuford again. And a lot of times people are treated with Tamiflu or one of the other neuraminidase inhibitors, and there has not been notable benefit in the United States. I don't know of any clinical trials that are looking at those particular antivirals. I know that they are doing a trial in China looking at that, and so there are some studies going on elsewhere around the world looking at other agents than what we're looking at, and so hopefully we will have some helpful data from other places, even if we don't have clinical studies up and running in the United States.
And Jennifer, I'd heard there was an anti-malarial that may have an effect. Had you heard that?
Yeah, I have too, but I don't know of where there's...
I think that was in China where they were doing a study, but you haven't seen any results out of that?
I have not, no.
Okay, excellent. Good. All right, our next questioner will be Dr. McMillan in Georgetown. Good evening, sir. Dr. McMillan, are you there?
Yeah, hey guys. So my question is, have we considered, and it's more to what Dr. Shuford was just saying, but a unified sort of message for people to set up expectations for treatment for this? I'm an emergency physician for reference. I read an article today about an Italian doctor, and he was begging the public to stop coming into the hospitals for this. And so my question is, what's the message and what's the goal? Are we just trying to diagnose a bunch of people, or what? Thank you.
No, good question, good point. We'll start with Jennifer.
So there is an element of us trying to diagnose people to find out where that disease is, but we still like to use our criteria. We know that even within the next week, we might have more cases and not want to be testing quite as frequently. We do already have messaging out to say that if you're mildly ill, that you don't need to access an emergency department or even your doctor's office, that you can take care of a mild illness if you're otherwise healthy. But if you're in one of those risk groups like I was talking about, that it would be advisable to call your physician and to get their input over the phone about how they should be triaged based on what their potential complications are. And so what we need to, and I understand what you're saying because we see this, don't we, in other like flu seasons when people are just inundating the emergency department when they don't need to necessarily. So we'll redouble our efforts at getting messaging out to really instruct people on when it's okay to stay home and just kind of look after themselves, that testing isn't always necessary because it's not like we have a treatment to give after a positive test. But if you're one of those high-risk groups, then those are the people, or if you're having severe or emergency symptoms, and those are the ones that we really want to direct to medical care.
And I suspect this will develop with time. I noticed that in Washington, one of the hospitals was trying to discharge patients because they were pretty full, and they were sending them home with pulse oxes, et cetera, to try and be able to monitor maybe medium disease at home kind of thing. So it's a very fluid situation. Our next question will be, let's see, Dr. Robin McCarty in Austin, I believe. I just flipped out of the way. There it is. Dr. McCarty. Good evening.
Good evening, and thank you for doing this. My question is, I don't know if it's a question or a comment, but I feel like we're in a double bind because we're being told we need to protect ourselves, yet we have no PPE to speak of. I mean, we can't even get regular surgical masks, let alone N95s. We have a few gowns. We have some, we have gloves. And so aside from phone triage and, trying to bring people through the back door, I mean, I feel like if I bring people in, I'm putting myself at risk, which then jeopardizes everybody else in my practice.
No, I think you're feeling the pain that we all are. John, I think, Commissioner?
Right. Well, it's a very difficult problem. There's no doubt about it. There are supply chain problems, and there's, as you notice, I mean, even things like hand sanitizer are out of the shelves and things like that. I think that there is a supply chain for many of the lower order technologies, if you will, like regular surgical masks that are in the United States, and I've been assured from our federal partners that they're working very hard to make sure that production ramps up in the U.S. and help try and meet that. I guess the best thing is that, we have to do the best with what we have available to protect ourselves. And I think in particular if a patient is symptomatic and any barrier that you could put that would cover their sneeze and cough over that patient would be something that would be helpful.
And John, just to clarify, I know that a few states, New York in particular, had PPE in reserve for disasters, but Texas did not. Is that correct?
Right now, the Department of State Health Services does not have a cache that's available. We are working to see if we can get our hands on some. I can tell you for sure, though, that, for instance, the Strategic National Stockpile absolutely does not have the capacity to supply large populations with ongoing needs of PPE over a period of time. So I think we'll be looking at really critical places. In other words, you can't continue to take care of ICU patients because you don't have masks and things like that, and we're going to have to make some very difficult choices. I think that's you're confronting it already. That's why I say this is going to be one of the greatest public health challenges in living memory, and there are limitations to what we have, and we're going to have to do the best under bad circumstances.
Excellent. Dr. Goslink in Marble Falls, good evening.
Good evening. In Texas, of course, we're all confronting spring break, and I'm getting quite a few questions in my practice about what to advise for travel. I was wondering, what are we telling people? Don't travel for spring break, or, don't go to Europe? I mean, obviously not to hot spots, but what is your specific advice for people considering travel?
So, again, great question. Please refer to our website. We do have what the official travel recommendations are from the State Department. In other words, the various stratifications that they have. I really feel, though, that if a patient comes to you for advice, feel free to give them the best clinical advice that you can, in looking at their individual situation and what they recommend.
Good. All right. We'll go next to Dr. Garrett in Austin. Dr. Garrett, good evening.
Hey there, Mike Garrett in Austin, Texas. And I have a dual-part question. So I think we have two problems that really are very significant. They've both been touched on, but testing is not nearly widespread enough, and we have to have more widespread testing. That's the first part of it. And then the second part, and it really integrates, is we have no access to protective equipment. And I'm a family physician seeing patients every day with respiratory illness, and all of our vendors have been on back order for at least 4 weeks since we've been trying to get N95 masks, for instance, for our patients. And we have no way to find out if these patients come in with respiratory illness that are the same symptoms as COVID-19 have that illness because the testing is so restricted. And we also have no way to protect even our own very staff with masks or protective equipment. So it's a dual problem. And what can we do? Is there any way that we can solve that dual problem? Thank you.
Well, let's touch on the first part of your question in the availability of the test and maybe what happens when it becomes ubiquitous. I think we've sort of addressed the problem with the PPE and the back order, and hopefully John's addressed that. So maybe, Jennifer, you could touch on the availability of the test and what that looks like should it become ubiquitous.
So right now we are seeing that commercial labs are coming online, like I mentioned, and so I expect increasing availability of that testing even over the next week, and so that's really encouraging news. There is sometimes a longer turnaround time for the commercial labs than for the public health labs that are within Texas, but I think that's going to be improving as well, and so at least part of that problem is going to be addressed. And then I know that Dr. Hallerstedt addressed some of the PPE issues, and CDC is also trying to address some of that with their recommendations and qualifying their recommendations kind of based on what is a PPE availability in different regions. And so we can hope for improved guidance for areas where we just don't have enough PPE to meet the current requirements.
Good. So we've got quite a few people in the queue, and we've got a captive audience here with our health officials. So I'm going to keep asking questions, and I'm going to go next to Dr. Siddiqui and McKinney. Dr. Siddiqui.
Hi, this is the office manager for Dr. Siddiqui. I have Dr. Siddiqui on the line here as well.
Go ahead.
We had a question about how this COVID-19 is showing up in children. We're hearing a lot about adults, and especially elderly, 55 and above, and those with underlying chronic illnesses, but not much about if these cases have shown up in children, even infants or babies, and if they have, how have kids responded to it, and if there's anything different that we are seeing if a kid has been exposed to it and has tested positive for COVID-19.
Hi, yeah, this is Jennifer Shuford. So we do know that children can become infected, and looking at, say, China's experience with their first 70,000 or so patients, what they noticed is that kids 18 and younger only accounted for about 2.4% of the infections, at least the infections that were diagnosed. And a lot of those that were diagnosed had mild illness. We do know that these kids, even if they're mildly ill or asymptomatic, actually do appear to shed the virus. They have pretty high levels on their NP and OP swabs when it's tested by PCR. And so we know that they're getting infected, but they do really seem to have mild illness on the whole. And many of these studies show if the kids have severe illness, that they get better, and that there's very few, if any, deaths. And so that's been really promising from the pediatric standpoint.
Excellent. Next, we're going to go to Dr. Kandawal in Plano, Texas. Doctor?
Yes. My question is, what is the advice for the small parties, group meeting, and how many people? Some advice about that.
Is there a critical number, a critical mass that we worry about? That's a good question. I don't know.
Right now, we're at kind of a tipping point right now where we don't have community transmission that we've identified in Texas, but we think we might be there because we know other states are there. And for now, we're just telling people who say are in those high-risk groups to really practice social distancing and not get around anybody. But even by the end of the week, we'll probably be telling everybody to stay 3 to 6 feet away from anyone else in their surroundings. And so I think we're coming to a place where even these small gatherings of 20 people really do become a risk for others that are in that room. And so I think that we are moving to a place where we're going to recommend even against those sorts of gatherings unless people can really be distanced from each other.
Fantastic. Dr. Crystal Berry Roberts in Austin. Good evening.
Hi. Can you hear me okay?
Yes, ma'am. We sure can.
Perfect. Thank you for taking these questions. I'm an OBGYN in Austin, and I was just curious about any particular recommendations or thoughts in regards to pregnant patients. We're getting kind of inundated with questions regarding should they travel, should they not? Do you have any information regarding fetal concerns or just maternal health as we're learning the effects of COVID-19?
Yeah, that's a good one we haven't hit on yet. So.
I know that there is a lot of concern about pregnant women, and thankfully there is some guidance on CDC's website, and we link to it from our DSHS website about FAQs for pregnant women, about how to handle infected women in labor and delivery, and how to keep that baby safe. And so I know that there is some guidance out there. Some of the early studies did not show pregnant women as being one of those high-risk categories, even though we've seen that with flu or some other illnesses that wasn't coming through in the data from the early studies. And we'll kind of continue to watch that. In the babies, they were seeing some preterm birth, and so that is a concern, but and there also has been some infections in really little babies, like within 36 hours of birth, but a lot of those were in women who delivered vaginally and not delivered by C-section. So I think there's still a lot to learn about pregnancy and safe delivery of a baby, and we're working on data, but for right now, they don't seem to be as high risk as some other groups.
And was it the WHO report that mentioned some C-sections where the baby did not acquire coronavirus?
Yeah, when the baby was delivered by C-section, they couldn't find evidence of that baby being infected with virus, and so that was really promising.
Excellent, excellent. Let's see, we're going to go next to Dr. Lukos in the Colony, Denton. Dr. Lukos, your question. Can you hear me? We might have to move on there. Let's go to Dr. Jalil in Waxahachie.
Hi, I'm one of the pulmonologist intensivists in Waxahachie, Texas. One of the problems that I was facing, especially with the new document that was released today with the PUIs, so a common patient for me in the ICU would be someone with end-stage renal disease or with ILD or some sort of severe disease that's listed on the list. and also have upper or lower respiratory symptoms and fever. When I look at the PUIs and when a layman or not someone who's an intensivist or pulmonologist looks at the criteria where either a travel history or having high-risk symptoms, it seems like it's being equated to being just as bad as having a travel history. And so that caused a little bit of hysteria in the hospital sometimes with, with staff thinking that this may be a patient who qualifies for COVID testing. So I don't know if you had any comments on that.
Yeah, I can understand your concerns there and maybe what you're experiencing. Again, those criteria are just to try to help us capture those patients that we need to know about from the public health perspective, and it's hard to communicate exactly, why those are our criteria. But I understand that you would have a lot of people who meet the criteria for testing if they have any sort of underlying health condition and they're in the ICU with lower respiratory disease. And what we are asking people is if their patient does not have those known risk factors of travel or exposure to a COVID-19 patient, that there is some preliminary workup for other infectious causes of a pneumonia or a lower respiratory disease, including just a flu test. We are still in our flu season here in Texas, and so asking that sort of screening be done. But we'll try to be cognizant of your concerns as we move forward with our testing criteria.
All right. Next, Dr. Lefkowitz in San Antonio. Dr. Lefkowitz. Good evening.
Actually, this is Dr. Garza. It's Dr. Lefkowitz is still working at the urgent care.
That's all right.
I'm the pediatrician in the family, and my husband's the one who works at the urgent care. And you had some excellent questions and answers by previous physicians, so I don't have to ask all of them. I just have two more questions. We have children in pediatrics who are not able to get their flu vaccines, and we know that infants and older children can get co-infections. So we've done PCRs in our office, and right now we're seeing the flu, the RSV, the croup. I'm curious, these people who've gotten the coronavirus, if they've also had co-infections with other viruses, and did any of these people also have the flu at the same time, is my one question. And then the other one, with those many emergency room doctors talking about the extreme number of people coming into the ERs, do you think the insurance companies are going to want to pay us pediatricians that talk to the families on the phone at this time of night to try to guide them about what they need to do? By payment for this kind of extra work that we're all going to be doing, because we're actually triaging at the front lines and trying to get the right people to the right places in this crisis that we're trying to prevent. So I just want to know we can get more flu shots for everybody in San Antonio, private and public, and also about getting payment for really doing telemedicine without being a telemedicine company.
This is Molly Mailmen. I can touch on the telemedicine topics, and then you can also refer back to our webpage on telemedicine. But Medicare will let you bill for a telephone encounter. Now, just letting you know, the reimbursement rate is not very high. It's not like an office visit, but you can bill that. It just needs to be within more than 7 days than when you saw the patient, because it will trigger a global. But you can set up those capabilities, and there's a ton of platforms out there that within a day or two can be set up, ready to go, that are HIPAA protected forms of electronic telemedicine messaging with your patients. So just go to our website, and there's a list of codes, and feel free to call our practice management department for specialized things for specific specialties, and we can kind of walk you through that on a one-on-one basis.
Excellent. Can I ask a question, a follow-up to that? Do you know what the policy for payment then is for Texas Medicaid for phone consultation?
Off the top of my head, I do not know for Medicaid, but I do know that usually Medicare allows the telephone encounter codes, so usually Medicaid follows, but I'm not 100% sure because Medicaid definitely reimburses at a lower rate.
Because as a fellow pediatrician, I completely identify with the fact that a lot of the value of your medical knowledge is something that you provide without compensation to those patients. And I was just wondering if Texas Medicaid had changed its policy and would allow at least some level of reimbursement for a telephone consult, but maybe folks could go to the Medicaid webpage, or you might be able to find out that information.
Yep, and it's ever changing right now too, just with the insurances seeing how we can handle things with getting certain things without needing prior authorizations, getting pushed through and paid for when you have the right information in the chart and you're billing the right codes. So I wouldn't be surprised if they come out with more information within the next week or two regarding that.
And I'd also mention that on our coronavirus page on the web page, we actually have an article on telemedicine and initiating that in your practice. So I'd recommend you go there to get more information. Wow, a lot of great questions. We're going to have to wrap this up because everyone's asked some good stuff, but time to move on. So it's helpful to hear what the members had in mind regarding the disease. If you did not get your question asked or have something else you'd like to ask or a comment, you can leave your question on a voicemail message at the end of this call. Here's how. When we conclude, you'll be prompted to press 1 to leave a voicemail. If you do, please be sure to leave your name clearly and contact information so TMA staff will reach out to you and reply to you within the coming week. Alternately, if you will email TMA anytime at knowledge@texmed.org, that's knowledge@texmed.org, and TMA staff will address things for you there. So in conclusion, I'm going to drop to the last question, which we have to ask is our CME question. Let's make sure you get your CME credit. Which step will you take as a result in participating in this CME event? Press 1 on your phone keypad if you will be applying the appropriate evidence-based criteria for evaluating suspected COVID-19 patients. Press 2 if you will prepare your clinic and develop specific practice management contingency plans to employ in the event of an outbreak in my community. Press 3 if you will begin educating your patients on how to protect themselves from COVID-19. Or press 4 if you will do all of the above. Once again, which of these steps will you take? Press 1 if you'll apply evidence-based criteria to evaluate suspected COVID-19 patients. 2 if you plan to prepare your clinic and develop specific practice management contingency plans in the case of an outbreak. 3 if you will educate your patients on how to protect themselves from COVID-19. Or press 4 if you plan to do all of the above. Now, Linda, I'm going to turn things back to you and close out tonight's TMA COVID-19 TeleTown Hall meeting. Linda.
Thank you, David. We want to thank everyone who has stayed on the call. We hope this TMA service has been beneficial to you. Our goal is to protect you as prepared as possible for this serious public health threat. I want to offer a very special thanks to our speakers this evening, Dr. John Hellerstedt, Dr. Jennifer Shuford, and TMA's Molly Mailmen. I also want to thank our moderator for the event, our esteemed TMA president, Dr. David Flieger. Physicians who remained on the call for at least 53 minutes will automatically receive their CME credit. For more information about this evolving situation, I encourage you to visit TMA's 2019 coronavirus webpage. That's again, texmed.org/COVID-19. Again, texmed.org/COVID-19. Once again, I'm Dr. Linda Villarreal. Thank you again for joining TMA's TeleTown Hall on the coronavirus-19. Good night to all.